كل القسم. انتم خلصتوا محاضراتكم كلها صح عبد الله؟ باذن رب العالمين. ضايل بكره الدكتور صهيب رح يجي معكم شويه ريفيو كانه اذا بدكم اي شيء باي وقت برضه احنا وي ار اوبن باي وقت بدكم اياه. بدكم تبعتوا على الفيسبوك على الجروب على التليفون وات ايفر. اي سؤال بدكم اياه سواء من هاي المحاضره او محاضرات ثانيه او اي محاضرات ثانيه احنا وي ار مور ذان ويلكم. هلا اليوم رح نبلش عن الجيت ديس اوردرز. الجيت ديس اوردرز we have to define the gait. The gait is a series of rhythmical alternating movements of the trunk and limbs that carry the body forward. It requires the integration of mechanism of locomotion with those of balance, motor control, and musculoskeletal function. The normal gait is smooth, symmetrical, and economical. I have to emphasize on the economical. It doesn't consume too much metabolism. Every step has its own ATPs, so we don't have to consume the ATPs as much as possible. A complete normal gait is the series of events that occur between the time one foot contacts the ground and the time the same foot returns to the same position. And what you call it, the gait cycle or the stride. We have two phases of the gait cycle. We have the swing and the stance phase. The stance phase is from heel strike to toe off when the foot is on the ground and load bearing. It's almost 60% of the gait cycle. The swing phase when the foot is off the ground when طاير بالهواء, typically from the initial swing toe off to initial contact heel strike of the one extremity. Usually it is 40% of the gait. Now we can either classify the gait cycle more than the stance and the swing. The stance has 4 phases from the initial contact. We are talking about this limb, but in the meanwhile, the other limb is going on the cycle for its own cycle. So we have going over this limb. We have the initial contact, the loading response, the mid stance, the terminal stance, the pre-swing. Then we have the swing phase, which is the initial swing, mid swing, and terminal swing. In the old terminology, we have called it the heel strike, flat foot or foot flat, mid stance, heel off, toe off, acceleration, mid swing, and deceleration. In each phase of this cycle, we have the contribution of the muscles. According to the contribution of the muscles, we have the normal gait cycle. Any imbalance of this pattern, we have abnormal gait cycle. In this one, I want to show you one thing. You notice the double support. We usually have the double support for the whole cycle, almost 20% in the initial contact and in the pre-swing phase. So the initial contact, the heel strike, is when the foot contacts the ground. Usually the hip extensors contract to stabilize the hip. The quadriceps contract eccentrically, and the tibialis anterior contracts eccentrically. So there's a difference between the contractions of the muscles. We have concentric contractures, and we have the eccentric contractions. When the muscles contract concentrically, in the concentric method, there's a shortening in the muscles, act the power to give the strength. In the eccentric contracture, and the other way around, it elongates. An example for that, when you do a dumbbell, when you do a dumbbell for the biceps, when you do flexion for the biceps in a resistant matter, you have a concentric contraction for the biceps. The other way, you have an eccentric contraction for that biceps. The loading response, then another stance phase is the loading response, the initial double limb support. It occurs after initial contact until elevation of the opposite limb. Usually the ankle dorsiflexion, tibialis anterior contracts eccentrically to control the plantar flexion moment. The quad contracts to stabilize the knee and contracts the flexion moment about the knee. Then we have the mid stance, the single limb support from elevation of opposite limb until both ankles are aligned in the coronal plane. The muscle contractures, the hip extensors, and the quads undergo concentric contractures. In terminal stance, single limb support begins when the supporting heels rises from ground and continues until the opposite heel touches the ground. The muscle contractures, toe flexors, and tibialis posterior contract and are more active during this phase. The last phase of the stance phase is the pre-swing, when we have the second double limb support from initial contact of opposite limb to just prior to elevation of ipsilateral limb. The muscle contraction, hip flexors contract to propel the advancing limb. Now for the swing phase, we have the initial swing from elevation of the limb to a point of maximum knee flexion. The muscle contraction, hip flexor concentrically contact to advance the swinging of the leg. The mid swing, that is with the foot clearance following knee flexion to point where the tibia is vertical. This is the muscle contraction, and this one, usually the ankle dorsiflexion to ensure the foot clearance. The terminal swing is that tibia is vertical from point where tibia is vertical to just prior to initial contact. Usually the hamstring muscles decreases forward motion of the thigh. We have to take some consideration, as we told you before, the single support, only one foot in contact with the floor, 40% of the gait cycle, and the double support, both feet in contact with the floor, 20% of the gait cycle. And how to examine? Now we have to go for how to have to examine the gait. Usually when we examine the gait, it begins as the patient is walking into the clinic, with the patient walking in a straight line, barefoot and in shoes. Observe him from behind and in front of the shoes. Evaluate what happens on each level, foot, ankle, hip, knee, and trunk during stance and swing phase. One of the examination in the patient gait, you have to examine his shoes. Sometimes there is when he is walking on the medial side, on the lateral side, you will find انه واحد من الجهات الفوت نهريه ببين انه في abnormal gait في عندهم. الجيت disorders نحكي عنهم هم mainly three patterns. Either it is due to pain, or it is due to muscle weakness, or it is due to loss of central nervous system control. We will start with the pain. Usually we call it the antalgic gait. Antalgic gait, limping due to pain, is called the antalgic gait. Its purpose is to reduce pain. Hip pain, patient lean towards the affected side as this decreases the compression force on the hip joint. Dash gait, we called it this antalgic gait. Pain in this lower limb is aggravated by weight bearing, so the patient minimizes the time spent in stance phase on the painful side. The back pain, usually axial rotation movement are minimized, resulting in a slow gait with small paces. Usually in antalgic gait, shorten stance phase and step length on painful side. Corresponding distance, increase in stance on unaffected side. Common cause is the osteoarthritis, tendinitis, lower limb arthropathy. This is an example for antalgic gait. Do you hear the video? سمعتوا الفيديو؟
لا دكتور ما في صوت.
طبعا خلينا نجرب هيك مرة. هلا هيك.
An antalgic gait refers to a painful limb. The patient's stance phase will be shortened on the affected side so as to limit the time and extent of weight bearing. Specific posturing depends on the affected area.
سمعتوا الفيديو؟
دكتور سمعنا.
في صوت
خلاص اوكي تمام. Now we have to go to limping or gait abnormalities due to muscle weakness. We have the Trendelenburg gait, waddling gait, and drop foot gait. This is maybe due to nerve or muscle atrophy. We have to start with the Trendelenburg gait. It is a normal gait. The normal gait, the hip abductors of the stance raise the contralateral hemipelvis. In Trendelenburg gait, abductors function is poor when weight bearing on the affected side, so the contralateral hemipelvis falls. This is a video.
A Trendelenburg gait is a repeated salty movement pattern during the...
You can notice on when she is moving on this one, the other side of the pelvis is dropping down.
Gait cycle.
So the common causes of Trendelenburg gait are weakness of the hip abductors, in polio, paresis, or superior gluteal nerve after total hip replacement, sexual hip joint problem like congenital dislocation of the hip, painful hip joint problems like in osteoarthritis. Now I have to say something about the Trendelenburg sign. So usually, the normal person, when you stand on one foot, the abductor of that foot prevents the falling down of the other foot to go down. In patients with Trendelenburg gait or Trendelenburg sign or weak abductors, the foot will go, or the pelvis will go down the other side. So the patient usually, to eliminate this or to decrease this one, not to drop the foot and not to falling down, he move his trunk to the other side. Again, usually not him to fall because of the falling down of this limb. He tried to move his trunk to the other side to control his limb. We will find it in patients with waddling gait. Waddling gait results from proximal limb weakness, most often from myopathy, but occasionally from a neuromuscular disease or proximal symmetrical spinal muscular atrophy. Usually we can find it in patients, or commonly we can find it in patients with bilateral DDH, because they have bilateral weakness of the abductors. With the weakness of hip flexion, the trunk is tilted away from the leg that is being moved to left the hip and provide extra distance between the foot and the floor. And the pelvis is rotated forward to assist the motion of the leg. Because the pelvic girdle weakness is bilateral, the pelvic tilt and rotation alternate from side to side, giving the waddling appearance to the gait. And
myopathies, usually we have weakness in the pelvic girdle region. And as I walk, if I can't stabilize my pelvis, then what ends up happening is that for the weight-bearing leg, I'm trying to stabilize the hip, and I'm coming off with the other, the pelvis will then dip or drop towards the non-bearing extremity. Now, if I continue in this attitude, I'll fall. In order to compensate for that, I'm going to shift my weight, and I'm going to try to put it over the weight-bearing leg. And so I'm going to actually swing the body towards weight-bearing leg and trying to get hyperlordotic and lock back over the hip that's stabilizing or is actually supporting the weight. So what will happen is that there will be a waddle as the pelvis will actually drop, come back up, drop the other side, and go back and forth instead of being nice and perpendicular to where it should be to the leg. So again, this is what it would look like. If I'm going to walk, as I take this step, the pelvis will drop, I'll shift this way, and then as I come through, I'll shift this way, the pelvis will drop on the opposite side, and there will be a waddle. I'm in the hyperlordotic position, trying to maintain my balance. Okay. So the pelvis drops, shifting to the opposite side.
So that was the waddling gait. Now we will go for a high steppage gait or the drop foot gait. When there is a common peroneal nerve injury, lumbar radiculopathy, tibialis anterior rupture, anterior tendon rupture, the patient cannot really clear the foot when he do the dorsiflexion. There's no dorsiflexion on the foot. So he weakens the dorsiflexion. Because of partial or complete foot drop, the leg must be lifted higher than the usual to avoid catching the toe on the floor during the forward swing of the leg. And here is this video.
The next gait is going to be that of a neuropathic gait in which the distal lower extremity is affected. For this particular gait, the person has the inability to dorsiflex the foot, and so the foot is actually a foot drop, and the person must step high in order to clear the foot. So if I don't step high enough, I'm going to drag the toe of the shoe, and so what happens is the person steps high to be able to clear the foot. As the foot drags, where's the foot drop position?
He has to try to move his foot up so that he clear the foot and not to touch the floor. And now we will go to abnormal gait caused by loss of central nervous system. We have the hemiparetic gait, we have the paraplegic or paraparetic gait, we have the Parkinsonian gait, apraxic gait, and the cerebellar ataxic gait. In hemiparetic gait, we call the circumduction gait due to unilateral upper motor neuron lesion. It's characterized by the arm is adducted and internally rotated with flexion of the elbow, extension of the hip, knee, and the ankle, forward swing of the leg during walking, equal abduction, circumduction at the hip, often with contralateral tilt of the trunk to prevent the toes catching on the floor as the leg is advanced. It's common mainly in patients after stroke, and we can watch the videos together.
This gait, if we were to demonstrate it, we need to be able to show the extension of the leg and internal rotation. So the leg is too long. We get circumduction with the paretic side. But very importantly as well is that the upper extremity is very much involved. And so there's adduction of the shoulder, flexion of the elbow, pronation of the wrist, the thumb is tucked under, and a cortical fist. So this is the position of the hemiparetic gait, with the other side being normal, having normal associated movements. You can actually hear the pattern of the gait as well, as we have circumduction for the paretic side. Again,
now we will go to the paraparetic gait. We are calling the scissoring gait due to the bilateral upper motor neuron lesion. Both legs are moved in a slow, stiff manner with circumduction, similar to the leg movement in the hemiparetic gait. In many patients, the legs tend to cross with each other for warning, swing, and scissoring. It's common signs of spinal cord disease and also increase in cerebral palsy. Most commonly, we see it in patients with cerebral palsy, paraplegic cerebral palsy. This is the video.
Is the spastic diplegic gait. In this particular gait, both lower extremities are affected, and the lower extremities are affected more than the upper extremities. So the posture, the position in this particular gait is there's flexion at the hips, flexion at the knees, and the feet or the ankles are extended and internally rotated, and there's also tight adductors, so there's adduction at the knees. So it is a swinging gait with both sides.
Tiptoeing, or he have a tight Achilles tendon. He will stand or walk on his toes. He cannot put his heels on the floor. Usually, this patient with paraplegic cerebral palsy. Excuse me. Watch it again.
Is the spastic diplegic gait. In this particular gait, both lower extremities are affected, and the lower extremities are affected more than the upper extremities. So the posture, the position in this particular gait is there's flexion at the hips, flexion at the knees, and the feet or the ankles are extended and internally rotated, and there's also tight adductors, so there's adduction at the knees. So it is a swinging gait with both sides, both lower extremities. You can hear a different pattern than the paretic gait. But this is not all. The upper extremities are also involved. Again, not as much as the hemiparetic gait, but for the upper extremities, the extremity is carried in a low guard or a mid guard position, and you don't have the normal associated movements in the upper extremity. So this would be the type of posture and type of position that one would see for the spastic diplegic.
Usually, these patients move forward from the truncal position rather than flexion of the hips or the hip flexors. And now, in Parkinson's disease, walking is initiated slowly by leaning forward and maintained with short, rapid steps, during which the feet shuffle along the floor. And there is a loss of arm swing. The stopped posture and impairment of postural reflexes can result in a rapid, short step, hurrying, or fast-feet gait. This is the video. You all know.
Is the gait that is hypokinetic gait. The prototype is Parkinson's or Parkinsonian type of gait, in which the patient will have a posture which will be stooped over, leaning forward, and then will have difficulty as far as initiating gait. When the gait is initiated, there are small steps. Oftentimes there's a tremor associated with this. And as the gait progresses, there may be a picking up of speed, or what's called a fenestrated gait. And then in turning, instead of having the normal turning, the patient will turn en bloc, which means they'll turn almost as a statue moving around. And then, again, having difficulty starting in the marche petit pas.
And the apraxic gait, usually this results from bilateral frontal lobe disease with impaired ability to plan and execute sequential movement. There's normal power in the legs and no abnormal cerebellar sign or proprioception loss, yet the patient cannot formulate the motor act of the walking. It is pathognomonic, gluing to the floor on attempting to walk, or wide-based unsteady gait with a tendency to fall. You can notice.
Try to take some steps.
You can notice how he is hardly moving his limbs out of the floor. This is what we call gluing walk.
Now, see if you can keep going without pulling them.
Okay, without me.
Try to take some steps.
The last one is the cerebellar ataxic gait. The ataxic gait is a broad-based, unsteady gait like a drunken sailor, in which the speed and length of stride varies irregularly from step to step. With midline cerebellar disease, as an alcoholic, posture is erect, but the feet are separated, usually like the drunken patients.
The last gait that I'm going to demonstrate is the ataxic gait. The ataxic gait, the patient has difficulty narrowing the station and maintaining balance. So typically they'll have a wide stance, is trying to maintain balance, and that there oftentimes will be unsteadiness in the trunk. So there may be some truncal titubation, which is an anterior-posterior type tremor at about 3 hertz. And there's also a tendency to lunge or to jerk sideways, and the patient then has to catch themselves. Of course, one of the ways to bring out this particular type of problem is to narrow the station, asking the patient to walk tandem. So if I then am ataxic, I then try to walk tandem, then I'm going to have difficulty walking.
And this is in a posture you can identify what is the diagram, the usual pattern of the gait in each abnormality. The last topic that I want you to talk about is the limbing child. We have to classify it as acute one, or it is chronic, or it is from birth. The limbing child can be important. The age of the child is important to determine the likelihood of the cause. In acute, you have to consider the trauma and infection. You always have to ask about recent history, about recent vaccination, infections, and antibiotics treatments. You have to ask about pyrexia, early morning stiffness, and pain in the to help diagnose inflammatory conditions such as juvenile idiopathic arthritis. Patients usually from 1 to 3 years, when it is coming limbing, usually the most common cause is DDH. Others are present, but the most commonly it is either from DDH, usually high dislocation, as you get from the DDH part. And from 4 to 10 years, usually transit synovitis or irritable hip is the cause. And the last one, in more than 10 years, usually the slipped femoral epiphysis is the most common. And thank you. If there's any questions that I can answer. شباب.
دكتور في عندي سؤال اللي هو على اللي هي اللي فيها الجلوتيوس ميديوس، بس انا ناسي شو اسمها.
هلا في عندنا احنا هلا اذا كان في عندنا اب نورمال الجلوتيوس او الابدكترز abductors muscle weakness هي تونلنبرغ ديت. سؤال
ما فهمتها والله.
طيب هلا يوجوالي احنا بالوضع الطبيعي لما نوقف البني ادم على رجله الابدكترز بتشتغل على رجل واحده، يعني قبل ما يعني رجل مرفوعه الابدكترز ايش وظيفه الابدكترز تبعت الرجل نفسها اللي واقف عليها؟ انها تمسك البلفس ما يوقع. كيف تمسك البلفس ما يوقع؟ راح تشد البلفس، ترفع البلفس من هون، يعني هاي صارت كونتراكشر من هون، فهذا رفعت البلفس هيك. اوكي؟
تمام.
هلا هاي اللي لو الابدكترز ويك، لو هذا الابدكترز ويك ايش رح يصير بالبلفس؟ ما رح تمسكه وترجعه لتحت، فالبلفس رح ينزل لتحت.
تمام.
هلا البلفس رح ينزل لتحت عشان المريض ما يوقع، بده يحول السنتر اوف جرافيتي، بدل ما السنتر اوف جرافيتي لتحت وينزل معاه لتحت وتو فيل داون، ايش رح يصير معاه؟ رح يحاول يزيح الترانك تبعه لهي الجهه، بيحاول السنتر اوف جرافيتي بدل ما يكون هون ويزيد كل الويت تبعه، رح يصير سنتر اوف جرافيتي هون على الهيب نفسه.
تمام.
فلما يمشي he lean his trunk to the affected side. sign and position. هذا السؤال فهمته؟
فهمت، شكرا.
تمام. في أي سؤال ثاني؟
دكتور لو سمحت، الفيسز بالأول ديتيلز تاعتها يعني ضروري إنه
مش كثير مهم. لا مش كثير مهمة، لا بس إنه بدك تعرفوا شغلات معينة، إنه كل اكت من الجيت سايكل في مسلز رح تشتغل ومسلز لا، عشان هيك يعني هي الفكره في الموضوع. بس انا الهدف انك تعرفوا ايش هي الفيزز موجوده اساميهم، بس مش ضروري تعرف ايش المسل اللي بتنعمل. في كثير ناس بتلخبط فيها، في كثير ناس تتعامل معها، بس هدفك انك تعرف ايش هم الفيزز الموجوده، وانه واحد بيكون دبل سبورت وانه بيكون سنجل سبورت. حاله الرننج ما بيكون في دبل سبورت، دبل سبورت بالإليمينيت. وبحاله الفلاينج بيكون فيش سبورت من مره، لا سنجل ولا دبل. صح؟
يسلموا دكتور.
تمام. هي سؤال ثاني.
دكتور يعطيك العافيه. دكتور
يعافي عمركم.
هلا انا وهنا تاخرنا شوي، جينا حاضرين بس تاخرنا.
تمام. هلا احنا 28 واحد موجودين، في 3 مش موجودين. قول اياهم ولا نبدا نفس القصص الاولاد الصغار؟ لا، مين اللي مش موجود؟ طيب عبد الله موجود. ساجدة؟
نعم دكتور.
محمد السواقة؟